Acute abdomen peritonitis surgical consultation. Acute abdomen peritonitis is a life-threatening condition affecting approximately 1.5 million people annually in the United States, with a mortality rate of 10 to 30%. The pathophysiological mechanism involves bacterial infection leading to inflammation of the peritoneum, which can progress to sepsis and organ failure if not promptly treated. Key diagnostic approaches include clinical evaluation, laboratory tests such as white blood cell count, WBC greater than 15,000 cells/μl, and C-reactive protein, CRP greater than 10 mg per liter, and imaging studies like computed tomography, CT, scans. Primary management strategies involve early surgical consultation, broad-spectrum antibiotics, e.g., ceftriaxone 2g4 every 12 hours, and supportive care. The economic burden of acute abdomen peritonitis is substantial, with estimated annual costs exceeding $2.5 billion in the U.S. Prompt recognition and treatment are crucial to reduce morbidity and mortality. The condition requires a multidisciplinary approach, involving emergency medicine, surgery, and critical care specialists. Early intervention can significantly improve outcomes, with studies showing that delayed surgery is associated with increased mortality rates, 25% versus 10% for early surgery. Key points. Note: the incidence of acute abdomen peritonitis is approximately 1.5 million cases per year in the U.S., with a mortality rate ranging from 10% to 30%. Bacterial infection is the primary cause, with Escherichia coli, E. coli, and Streptococcus pneumoniae being common pathogens, responsible for 50 to 60% of cases. Clinical presentation typically includes severe abdominal pain, 90%, fever, 80%, and tenderness, 85%, with rebound tenderness present in 60% of patients. Laboratory findings include elevated WBC, greater than 15,000 cells/μl, in 80% of patients and CRP, greater than 10 mg per liter, in 90% of patients. CT scans have a diagnostic accuracy of 95% for detecting peritonitis and are the imaging modality of choice. Broad-spectrum antibiotics, such as ceftriaxone, 2g4 every 12 hours, and metronidazole, 500 mg for every 8 hours, should be initiated promptly. Surgical consultation is recommended for all patients with suspected peritonitis, with laparotomy indicated in 70 to 80% of cases. The Apache 2 score is used to predict mortality, with scores greater than 20 associated with a mortality rate of 50%. Patients with peritonitis are at high risk for developing sepsis, with 30% progressing to septic shock. The Surviving Sepsis campaign recommends administering antibiotics within 1 hour of sepsis recognition, with a goal of achieving a lactate level less than 2 millimoles per liter. Patients with chronic kidney disease require dose adjustments for certain antibiotics, such as ceftriaxone, 1g4 every 24 hours for GFR less than 30 milliliters per minute. Overview and epidemiology. Acute abdomen peritonitis, also known as acute peritonitis, is a serious and potentially life-threatening condition characterized by inflammation of the peritoneum, the thin layer of tissue that lines the abdominal cavity. The ICD-10 code for acute peritonitis is K65.0. Globally, the incidence of acute peritonitis is estimated to be around 2 million cases per year, with a mortality rate ranging from 10% to 30%. In the United States, approximately 1.5 million people are affected annually, resulting in over 200,000 hospitalizations and 50,000 deaths. The economic burden of acute peritonitis is substantial, with estimated annual costs exceeding $2.5 billion. The condition affects both sexes, although it is more common in males, 55% versus 45% in females, and can occur at any age, with the highest incidence in the 65 to 74-year age group, 25% of cases. Major modifiable risk factors include smoking, relative risk 2.5, obesity, relative risk 1.8, and diabetes, relative risk 2.2, while non-modifiable risk factors include age greater than 65 years, Relative risk 3.5, and history of abdominal surgery, relative risk 4.1. Pathophysiology. The pathophysiological mechanism of acute peritonitis involves bacterial infection, which can arise from various sources, including gastrointestinal perforation, appendicitis, diverticulitis, and intra-abdominal surgery. The most common pathogens involved are gram-negative bacteria, such as E. coli, 50 to 60% of cases, and Klebsiella pneumoniae, 20 to 30% of cases, and gram-positive bacteria, such as Streptococcus pneumoniae, 10 to 20% of cases, and Enterococcus faecalis, 5 to 10% of cases. The infection leads to the release of pro-inflammatory cytokines, such as tumor necrosis factor alpha, TNF-alpha, and interleukin-1 beta, IL-1 beta, which cause inflammation and damage to the peritoneal tissue. The disease progression timeline can be divided into 3 stages. The initial stage, 0 to 24 hours, characterized by localized inflammation. The intermediate stage, 24 to 48 hours, marked by bacterial translocation and systemic inflammation, and the late stage, 48 to 72 hours, characterized by sepsis and organ failure. Biomarkers, such as CRP, greater than 10 mg per liter, and procalcitonin, greater than 2 nanograms per milliliter, can be used to monitor disease severity and progression. Clinical presentation. The classic presentation of acute peritonitis includes severe abdominal pain, 90%, fever, 80%, and tenderness, 85%, with rebound tenderness present in 60% of patients. Atypical presentations, especially in the elderly, diabetics, and immunocompromised patients, can include vague abdominal discomfort, nausea, and vomiting. Physical examination findings include abdominal tenderness, 85% sensitive, 70% specific, guarding, 75% sensitive, 60% specific, and rebound tenderness, 60% sensitive, 80% specific. Red flags requiring immediate action include severe abdominal pain, fever greater than 38.5 degrees Celsius, and signs of sepsis, such as hypotension, blood pressure less than 90/60 millimeter of mercury, and tachypnea, respiratory rate greater than 24 breaths/min. Symptom severity scoring systems, such as the Apache 2 score, can be used to predict mortality and guide management. Diagnosis. The diagnostic algorithm for acute peritonitis involves a combination of clinical evaluation, laboratory tests, and imaging studies. Laboratory workup includes complete blood count, CBC, blood cultures, and inflammatory markers, such as CRP, greater than 10 mg per liter, and procalcitonin, greater than 2 nanograms per milliliter. Imaging studies, such as CT scans, have a diagnostic accuracy of 95% for detecting peritonitis and are the modality of choice. Validated scoring systems, such as the Apache 2 score, can be used to predict mortality and guide management. Differential diagnosis includes other causes of acute abdomen, such as appendicitis, diverticulitis, and intestinal obstruction. Biopsy or procedure criteria, such as laparoscopy or laparotomy, may be necessary to confirm the diagnosis and guide management. Management and treatment. Emergency stabilization involves administering oxygen, fluids, and broad-spectrum antibiotics, such as ceftriaxone, 2g every 12 hours, and metronidazole, 500 mg for every 8 hours. Monitoring parameters include vital signs, lactate levels, and urine output. Immediate interventions include surgical consultation and preparation for potential laparotomy. First-line pharmacotherapy involves broad-spectrum antibiotics, such as ceftriaxone, 2g every 12 hours, and metronidazole, 500 mg for every 8 hours. The mechanism of action involves inhibiting bacterial cell wall synthesis and protein production. Expected response timeline includes improvement in symptoms and laboratory parameters within 24 to 48 hours. Monitoring parameters include antibiotic levels, liver function tests, and renal function tests. Key points: pregnancy, safety category B, Preferred agents include ceftriaxone, 2g for every 12 hours, and metronidazole, 500 mg for every 8 hours, with dose adjustments necessary in the third trimester. Chronic kidney disease, GFR-based dose adjustments necessary for certain antibiotics, such as ceftriaxone, 1g for every 24 hours for GFR less than 30 ml per minute. Hepatic impairment, Child-Pugh adjustments necessary for certain antibiotics, such as metronidazole, 250 mg for every 8 hours for Child-Pugh C. Elderly, greater than 65 years dose reductions necessary for certain antibiotics, such as ceftriaxone, 1g for every 12 hours, and Beers criteria considerations necessary to avoid polypharmacy. Complications and prognosis. Major complications include sepsis, 30% incidence, organ failure, 20% incidence, and death, 10 to 30% mortality rate. Mortality data include 30-day mortality, 15%, 1-year mortality, 25%, and 5-year mortality, 40%. Prognostic scoring systems, such as the Apache 2 score, can be used to predict mortality and guide management. Factors associated with poor outcome include age greater than 65 years, comorbidities, and delayed surgical intervention. Escalation of care and referral to a specialist are necessary in cases of severe disease or poor response to treatment. ICU admission criteria include severe sepsis, organ failure, and requirement for mechanical ventilation. Recent advances and emerging therapies, 2020 to 2024. New drug approvals include ceftazidime-avibactam, 2g for every 8 hours, and meropenem-vaborbactam, 2g for every 8 hours, which have shown efficacy against resistant gram-negative bacteria. Updated guidelines from the Surviving Sepsis campaign recommend early recognition and treatment of sepsis, with a goal of achieving a lactate level less than 2 millimoles per liter. Ongoing clinical trials include studies evaluating the efficacy of novel biomarkers, such as procalcitonin, and emerging surgical techniques, such as laparoscopic peritonitis treatment. Patient education and counseling. Key messages for patients include the importance of seeking medical attention immediately if symptoms persist or worsen, and the need for adherence to antibiotic therapy and follow-up appointments. Medication adherence strategies include using a pill box and setting reminders. Warning signs requiring immediate medical attention include severe abdominal pain, fever greater than 38.5 degrees Celsius, and signs of sepsis. Lifestyle modification targets include a healthy diet, regular exercise, and avoidance of smoking and excessive alcohol consumption. Follow-up schedule recommendations include regular appointments with a primary care physician and specialist, as necessary. Clinical pearls. Note: the diagnosis of acute peritonitis should be considered in any patient with severe abdominal pain and fever. Broad-spectrum antibiotics should be administered promptly, with a goal of achieving adequate coverage against gram-negative and gram-positive bacteria. Surgical consultation is recommended for all patients with suspected peritonitis, with laparotomy indicated in 70 to 80% of cases. The Apache 2 score can be used to predict mortality and guide management. Patients with peritonitis are at high risk for developing sepsis, with 30% progressing to septic shock. The Surviving Sepsis campaign recommends early recognition and treatment of sepsis, with a goal of achieving a lactate level less than 2 millimoles per liter. Novel biomarkers, such as procalcitonin, may be useful in diagnosing and monitoring peritonitis. Emerging surgical techniques, such as laparoscopic peritonitis treatment, may offer improved outcomes and reduced morbidity. Patients with chronic kidney disease require dose adjustments for certain antibiotics, such as ceftriaxone, 1g for every 24 hours for GFR less than 30 milliliters per minute. The Beers criteria should be considered when prescribing medications to elderly patients, to avoid polypharmacy and potential adverse effects. References. 1. Lucier G. et al. Compact arterial monitoring device use in resuscitative endovascular balloon occlusion of the aorta, Reboa, a simple validation study in swine. Curious. 2024, 16, 10E70789. PMID, 39493181, https://pubmed.ncbi.nlm.nih.gov/39493181. DOI 10.7759/curious.70789. 2. Base GA et al. Tertiary peritonitis, considerations for complex team-based care. European Journal of Trauma and Emergency Surgery, official publication of the European Trauma Society. 2022, 48, 2811-825. PMID 34302503, https://pubmed.ncbi.nlm.nih.gov/34302503. DOI 10.1007/S00068-0210175-9. 3. Sequinine JPB et al. Epidemiological, clinical and prognosis aspects of acute generalized peritonitis in South Kivu Province, descriptive observational study of 278 cases. The Pan-African Medical Journal. 2024, 47:1. PMID 38371644, https://pubmed.ncbi.nlm.nih.gov/38371644. DOI 10.1160/PAMD.2024.47.1.38288. 4. Porous LE et al. Omental infarction, unusual cause of abdominal pain. Andes Pediatrica, Revista Chilena de Pediatria. 2022, 93, 3434-439. PMID 3585716, https://pubmed.ncbi.nlm.nih.gov/3585716. DOI 10.3264/1/andispediator.v93i3.3830. 5. Kirkpatrick A.W. et al. The Unrestricted Global Effort to Complete the COOL Trial. World Journal of Emergency Surgery, WJES. 2023, 18, 133. PMID 37170-123, https://pubmed.ncbi.nlm.nih.gov/37170-123. DOI 10.1186/S13017-023-00500Z6. Ephenegus A.D. et al. Treatment outcomes of acute appendicitis and associated factors among admitted patients with a diagnosis of acute abdomen in Debre Marcos Referral Hospital, Amhara Region, Northwest Ethiopia. Journal of Perioperative Practice. 2022, 32, 5123-130. PMID 326386553, https://pubmed.ncbi.nlm.nih.gov/326386553. DOI 10.1177/175045892092847. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.